Good morning, everyone. Returning today is Dr. Dave Gilbert for what's become his annual Stump the Stars Best ID Cases. This event has been a highlight of the annual Infectious Disease Society of Oregon meeting. Dave is currently Chief of Infectious Disease at Providence, Portland, and I think you all know that he's an icon of infectious disease nationally, if not internationally, and really needs no further introduction. So I give you Dave Gilbert.
Thank you. Okay, this is always fun, and as Richie mentioned, we presented these cases down in Salem last November, but there's nothing more mutable than infectious disease. Things change so fast that we've added a few wrinkles based on current activities in the world of infectious disease. These are my required disclosures. Down in the Infectious Society of Oregon, we have the Stump the Stars format. Because of time constraints today, I'm not going to call on my colleagues. They actually know several of these cases anyway. And I was going to have the audience respond. I'll certainly invite your questions, but I'm not going to go through the process of having you guess the answer, et cetera, just for reasons that I want to get through what I think are some educational cases. We'll start with a patient with a sore throat. This was a 34-year-old married male radiation therapist at one of the Portland hospitals. Complains of a sore throat for 3 days. He had some associated fatigue and occasional productive cough, and maybe he thought some subjective fever, but he didn't take his temperature. Review of systems, past medical history. He takes Ritalin for adult attention deficit disorder, omeprazole for some mild GERD, Wellbutrin for chronic depression. And then in terms of allergies, his mother told him that maybe he reacted to penicillin in early childhood. Not clear. Physical exam and selected labs. He wasn't febrile at the time of his initial physician contact. Other vital signs were quite normal. But everybody was impressed with a large, firm right cervical chain lymph node. The oral exam, as reported, and the oral pharynx exam were unremarkable. White count, not impressive. Hemoglobin, hematocrit, platelets, chemistry screen, everything looked okay. But the CT scan of the neck sort of was inconsistent with the physical exam because, as you'll see in the next image, the right tonsil was quite enlarged, and then there was this right cervical lymph node. Now, I would have thought if I looked in the mouth of this patient, it would have looked quite abnormal, even though in the chart it said nothing remarkable. And then there was this large lymph node evident on the CT scan. So the preliminary differential diagnosis, I have to emphasize infectious diseases was not involved at this point in the care of the patient, was this could be infectious mononucleosis. Well, the one lymph node, not a lot of lymph nodes, a little older for the usual patient with infectious mono. The CBC showed no atypical lymphocytes. That didn't seem terribly likely. Strep pyogenes pharyngitis, what's that got to do with the lymph node? Well, you can certainly get lymph nodes, but not usually just one lymph node. You would have thought the exam of the throat would have been abnormal. The doctors caring for the patient were worried about a lymphoma, although they didn't find any lymphadenopathy anywhere else. And then you could proceed down a long list of other possibilities. Subsequent events were pretty dramatic. They did a rapid strep test. That was negative. They did a mono test, not as a surprise. That was negative. Then they were worried a lot about this lymph node, so they biopsied the lymph node looking for the malignancy, for the lymphoma, and the report came back as no malignant cells. And then, this sort of blew me away, ENT decided to remove the tonsil. Path report came back several days later as negative for lymphoma or other neoplasm and described nonspecific inflammation. So what is going on? So this all took several weeks to accomplish while the patient intermittently was still complaining about sore throat, difficulty swallowing, depending on what he ate, et cetera, et cetera. So they asked for an infectious disease consultation, and this was after 4 months of symptomatology. So we do what we do in infectious disease. We took a history. And it turns out this was a bisexual male, and he admitted performing oral sex on an anonymous partner roughly 6 weeks before the onset of his symptoms. So what do we need to put in the differential diagnosis now? Yeah, I heard some good ideas there. So now the differential diagnosis goes to all of the sexually transmitted diseases. So acute HIV, herpes simplex type 2, treponema pallidum, Neisseria gonorrhea, human papillomavirus, no papillomas were seen, of course, and chlamydia trachomatis. So repeated the physical examination in the labs. The cervical node was still present, and now, and in fairness to earlier providers, a rash wasn't present before, but now the patient has a diffuse macular papulosquamous rash, and I'll show that to you in a moment. Throat exam was benign, although there was some asymmetry of the throat. CBC chemistry screening were unremarkable. 10% of patients with infectious mono never get a positive mono test, so went looking for antibody to the Epstein-Barr virus, and the antibody panel was positive, but in a pattern that was consistent with remote past infection. And then for the possibility of primary HIV, a viral load for the HIV virus was performed, and that was negative. It should have been very, very positive if this was primary HIV. And so the rash is present diffusely, but including the palms and the soles. So now what's your diagnosis? Oh, you're so good. So the RPR was positive at 1 to 256. Treponemal antibody was positive. He was given 2.4 million units of benzathine penicillin G, and then because that allergy history was kind of iffy, the penicillin was tolerated beautifully, and there was resolution of the throat pain, rash, and the lymph node shrunk. And 3 months later, as one would hope, his RPR titer, which started at 1 to 256, appropriately decreased to 1 to 4. And then they went back and looked at the lymph node that was resected. And there are the spirochetes that were missed on the initial evaluation. So pharyngitis, tonsillitis, adenitis, it's really rare in defense of the providers. It's a rare presentation for syphilis. Incidence of syphilis is increasing among men who have sex with men, and it is true that there's a high co-infection rate with HIV. And so this was in hindsight, the postulated chain of events. Was contact of the pharynx of the patient with a painless, remember they're painless, chancre on the penis of his sex partner. No chancre was found in our patient. If it was seen, the etiology would have been, serology rather, would have been negative as it is in primary syphilis, and you would have needed dark field to make that diagnosis. We postulated that the tonsillitis, adenitis, was the onset of his secondary syphilis, which can last several weeks. And then had nothing been done, the patient would have gone on, resolved the rash, and gone on to latent syphilis. So in men that have sex with men, the CDC recommends annual lab work that includes HIV antibody if they're known to be negative, annual urine screens with nucleic acid amplification tests for Neisseria gonorrhea and chlamydia, and now syphilis antibody is added to that list because of the current epidemic, if you will. So this was reported in the New England Journal, and the bottom line was the patient's history is not complete without a sexual history. Any comments on that case? I think the lesson is obvious.
Did you consider scrofula?
Yeah, there was no exposure history, scrofula due to mycobacteria, and obviously there were no granulomas. Once you had that pathology on the lymph node, you should have seen granulomas.
Dave, can you say a few words about reverse syphilis testing in the lab?
Yeah, that's become the standard. The algorithms are all there in EPIC as to how to proceed. We now start with a syphilis antibody test rather than the non-specific screening RPR test.
Providers who took care of him in those 4 months need treatment?
I'm sorry, I could only hear part of that.
Do any of the providers who took care of that patient in the 4 months need treatment?
I still didn't catch it all, so I'm so sorry.
So do any of the providers that took care of that patient that were exposed to him, do they need treatment?
No, there's no sexual exposure. No. The mucous membranes certainly would be teeming in classical secondary syphilis, so if you had an accidental exposure, a cut on the provider's hands or something, it's just conceivable that you could acquire syphilis in that way. Okay, let's go on to our second case, fever and hemorrhagic pneumonia. 44-year-old male business executive is an avid hunter and fly fisherman, and he presents to the emergency department with 5 days of increasing shortness of breath and a cough that was initially non-productive but now is producing bloody sputum. And he's got a review of systems that's positive in many ways. He's got headache and photophobia. He's got bilateral calf pain. His exam in the emergency department shows definitely fever, tachypnea, hypoxia, requiring 10 liters of oxygen per minute by nasal cannula. He's tachycardic, blood pressure is a little low for him, and he appears critically ill. The sclera are red without any conjunctival exudate, diffuse rales. He's icteric. No signs of pruritus, but he's icteric, and no rash or other focal lesions. Because of his significant hypoxemia, he's immediately intubated. So the additional history comes from his wife. So the family just returned from 2-week vacation in Costa Rica, Central America. And while the family stayed in luxury hotels, the patient, being an avid fisherman, went fly fishing for 3 to 4 days with a guide. The access to the fishing streams required hikes through pastures containing livestock, around waterfalls, and through dense jungle vegetation. He stayed in isolated mountain park cabins. Suffered many mosquito bites, of course. Sampled the local foods. He was into it. He did receive, prior to travel, recommended vaccines and advice on prophylaxis from a travel clinic. So non-smoker, except for occasional cigars, alcohol in moderation, no illicit drug use, and the sexual history here was unremarkable. So the initial lab results, hemoglobin's a little low, white count's a little high, platelets are okay. Total bilirubin is indeed elevated with mild increase in his AST and ALT. The INR was normal. CPK is elevated, and his creatinine is elevated with an active urinary sediment. He's got 40 white blood cells and some red cells per high-powered field, spilling some protein and spilling some glucose. Chest x-rays, very abnormal. They proceeded, I'm not sure why, to a CT scan of the chest, which is really abnormal. So he had evidence of meningitis, fever, headache, so they did an LP, and you can have up to 12 lymphocytes in your CSF, and it's within the 2 standard deviations of normal, but he had 70 lymphocyte predominant, so he's got a pleocytosis in his spinal fluid. Protein is elevated mildly to 60, glucose is okay, cryptococcal antigen was negative, Gram stain was negative, and I can tell you now that ultimately the cultures were also negative. So this differential diagnosis can be quite long, but a partial differential diagnosis includes leptospirosis, multi-system disease. He's got hepatitis, nephritis, the aseptic meningitis, bacterial pneumonia. Hard to explain the other manifestations I just mentioned. He was in the endemic area for dengue. Dengue causes a hemorrhagic fever, but it doesn't, except rarely, cause a severe pneumonia that would be to the point of hemorrhagic. Chikungunya, also endemic in the Caribbean and the countries that are immediately adjacent to the Caribbean and Central America. Why do I put Coxiella burnetii here? Coxiella burnetii is the etiology of Q fever. It's the livestock exposure. So as the wife related, they walked through pastures that were occupied by livestock, and the products of conception of the livestock create these aerosols, or can create these aerosols of Q fever. And then we all remember the Sonoma virus, the hantavirus pulmonary syndrome from the mouse droppings in the cabins. We had we've had outbreaks around the country. It was last summer in Yellowstone. It's in Yosemite, rather. So this is at least a partial infectious disease differential. This is to remind you of where dengue is endemic. So the southern U.S. bordering the Caribbean, Mexico, Central America, Latin America, Sub-Saharan Africa, and then the Middle East and the Far East. And this coincides, of course, with the range of the vector, which is the Aedes aegypti mosquito. Chikungunya has exactly the same, but neither dengue or chikungunya have this multi-system involvement. They primarily are fever and fatigue, and then occasionally you can get hemorrhagic dengue, but to have nephritis, meningitis, etc. would be unusual. And then this is from the World Health Organization distribution of the Aedes aegypti mosquito, and red signifying those geographic areas where the highest density of the mosquito vector is located. Hantavirus pulmonary syndrome, I couldn't find any epidemiologic data about hantavirus in Central and America, Latin America, and so forth. It wouldn't surprise me if it was there. It's mouse droppings that spread the virus. Most of the cases in the U.S. have been California, Arizona, New Mexico, and Colorado. And the total number of cases in Oregon, acquired in Oregon, is quite small at this point. So the patient was given empiric ceftriaxone and doxycycline, which would be appropriate for empiric therapy of leptospirosis. That would be the ceftriaxone. The doxycycline for the Q fever, if that was a possibility. 3 or 4 days of high doses of solumedrol were given, not sure why. Waiting for the return of the diagnostic test. Patient was slowly weaned off the ventilator. Sputum and blood cultures came back negative, and a week later there were negative serologies for the hantavirus, Q fever, chikungunya, and dengue. So the diagnosis was believed to be leptospirosis, and a serology came back with a very high antibody titer to leptospira. PCR and culture were not done. Increasingly, PCR is available, which will be a much nicer way and quicker way of making the diagnosis. And there are these maps of reported leptospirosis outbreaks, and they certainly occur in the United States, in Hawaii, but also in Mexico, Central America, and Latin America. So the patient was clearly in an area and engaging in an activity that would lead to exposure to leptospirosis. So once the patient was better, we were able to get additional history. He inhaled lots of spray from the waterfalls while fishing. He saw rodent droppings, but didn't actually see the animals. And he often fished while wading in, this was a tropical country, of course, while wading in sandals with lots of exposure of the skin of his legs and feet to the water. So leptospirosis is fascinating. It's had lots of names attached to it. Weil's disease, that's severe leptospirosis, where you have involvement of the liver and kidneys. It's been called cane field fever. Again, lots of rodents in the cane fields. Rat catcher's disease, rat catcher's yellow disease. There's over 200 variants of the spirochetes that cause leptospirosis, and the specific variants are correlated with the geographic area where the patient is exposed. The disease severity varies from mild to life-threatening, and the hint is the multi-system involvement. Patient had red eyes, presumably the uveitis, aseptic meningitis, hepatitis, nephritis, and the CPK elevation suggests myositis. And we mentioned the diagnostic methods. Treatment is controversial, but usually given, at least empirically, ampicillin, doxycycline, penicillin, ceftriaxone. So we don't have a problem finding appropriate antimicrobic therapy. Has there ever been a prospective randomized double-blind study showing superiority of the antimicrobials over placebo? No, and that probably won't happen. Steroids are controversial. So it's the free-living leptospira that are in the urine of often asymptomatic animals, wild mammals, or the rats that live in close to human domiciles, so that humans have lots of opportunities to be exposed, and these are just some of the reported exposures in the literature. The urine then of the infected animals contains the spirochete, and the spirochete is capable of burrowing through intact skin as the way of getting into the human. And this just again to emphasize the multi-system involvement, uveitis, meningitis, myocarditis, which I hadn't mentioned, and the pulmonary hemorrhagic syndrome. So in summary, leptospirosis is part of the differential diagnosis of fever and hemorrhagic pneumonia. The hint is the multi-system involvement. The exposure history is crucial. Until rapid PCR methods become available, the initial diagnosis is clinical with subsequent empiric therapy. For the residents and medical students in the room, leptospirosis is always an answer on board exams. It's always there. You just have to find it. Questions or comments?
How about native populations who hunt fish routinely? Are they subject to this disease as much as
Populations of what?
are exposed to hunting and fishing?
Yeah, they're at increased risk, of course.
So do you see it a lot in Central America?
Well, you see it a lot in Central America, is that what you said?
Yes.
The epidemiologic data there is so poor, I think the answer is we don't know. Every time they look for it with increased intensity in the United States, various state health divisions, they find more leptospirosis than they thought was there. Well, I have to tell you that this next part of this case was made up. And it was made up in light of current events in Latin America and South America. So we'll say leptospirosis was not enough for this poor family. One day after returning home, our last patient's 35-year-old wife developed a fever of 38.3, a pink non-paretic rash on her arms, and minimal joint discomfort. She was worried about Zika with all of the publicity that disease has experienced. Her primary care physician ordered a pregnancy test. And of course, for this purpose of this presentation, it was positive. On exam, she has a rash, fever, mild conjunctivitis, but she doesn't feel that bad. CBC, multichemistry screen are essentially normal. So how do we make a specific diagnosis? So that's a typical rash, obviously completely nonspecific. And that's the devil, if you will. The Aedes aegypti mosquito, easy to identify because of the black and white banding on the trunk and the appendices. It's the reservoir animal, if you will, for chikungunya, dengue, and the Zika virus. In distinction to the mosquitoes that spread malaria that feast on humans at night, the Aedes aegypti mosquito bites during the day. It's both urban and jungle locations, anywhere that there are some standing water where they can deposit their eggs. And again, this is the same map I showed earlier of the distribution of the Zika virus, which includes the hotbeds of the Aedes aegypti mosquito, which includes the hotbeds for the Zika virus in Latin America. So the differential diagnosis, this is just electron micrograph showing what the Zika virus looks like. A differential diagnosis in our fictitious patient is the Zika virus, dengue, chikungunya, yellow fever. She probably was immunized for yellow fever before the trip, or may have been immunized. The reason I have the asterisk here are these are all flaviviruses, and the other flaviviruses are which aren't pertinent to this patient are Japanese bee encephalitis, West Nile, and St. Louis. So when we order antibody tests, which is one of the ways of making the diagnosis, you're always worried about cross-reactivity with prior exposure to or concomitant exposure to other flaviviruses. So the laboratory diagnosis for the first 7 days of clinical illness, it's an RNA virus, and the RNA of the virus is in the blood. So reverse transcriptase polymerase chain reaction is the most sensitive and specific test to do while the virus is still circulating. It only circulates for like 7 days. The illness lasts 3 to 5 days typically. And then during the initial convalescent stage, you still may be able to detect the virus. So up to maybe 10 days at the most, you could anticipate the PCR to be positive. You can detect IgM antibody 3 to 7 days after onset, and of course the antibody will persist for months. The problem is this cross-reactivity with other flaviviruses, and especially with dengue and West Nile, St. Louis encephalitis, people have gotten the yellow fever vaccine, et cetera. We don't have any commercially available diagnostic tests for Zika that I know of up until this point anyway. It's recommended in Oregon that you send the serum to the state public health laboratory or directly through the hospital lab, and the hospital lab will send it to the county health department, who will subsequently send it to the state public health lab. So it ends up at the state public health lab, and they'll do the antibody tests. The CDC, everybody's worried about the pregnancy implications, and the CDC website on Zika is really wonderful. And just a few days ago, they updated their guidelines for women exposed to the Zika virus. Pregnant women with history of travel to an area with ongoing Zika do the test. If it's positive or inconclusive for Zika, then really all you have to offer is serial fetal ultrasounds. You could consider amniocentesis and doing a PCR for Zika. If it's negative for the Zika virus, the initial test is negative. Fetal ultrasounds to detect microcephaly, and you can follow that. If the microcephaly or intracranial calcifications are not present, it's just routine prenatal care. Obviously, if it's abnormal, then you can proceed along that part of the algorithm. So the Zika clinical illness is mild and self-limited. The main thing we worry about is mother-to-fetus transmission. So now the question that still is a major question is whether Zika can cause microcephaly. In Brazil, 3,500 cases from October 15th to January 16th. Driving to work this morning, listening to NPR, they said this number is now 5,000. So whatever it is, it's a big number. Other congenital abnormalities, especially ocular abnormalities, have been described. Guillain-Barré has been reported sporadically and rarely after a variety of viral infections, and that's been associated with Zika, but not with any great frequency. So why are the reports of microcephaly so far only from Brazil? So Zika was described way back in the late 1940s and early 1950s from the Zika forest in Uganda. My pointer work here. In Uganda, subsequent outbreaks have occurred in the Middle East and the Far East, a huge outbreak in Micronesia, and this is all spanning the last 50, 60 years. And now we have the outbreak in Mexico and Latin America and Central America. And each time the virus spreads by the infected mosquito, you have this huge population that have never seen this virus, so there's no circulating herd immunity, and we have a huge outbreak. But what struck some infectious disease public health colleagues in Argentina is that in all these other outbreaks, there's been no microcephaly. So they said, is there anything else involved? So that's created this postulate and this huge roaring controversy about the larvicide pyriproxyfen, I'm probably not saying it right. Anyway, the public health authorities in Brazil, trying to control the Aedes aegypti mosquito, decided to add this larvicide to the water supply of the country in 2014. The number of cases of malformation correlates with the areas with the greatest use of pyriproxyfen. In other outbreaks in other countries, despite infection in 75% of the population, there's been no microcephaly. The website for the manufacturer, which is a subsidiary of Monsanto, says that pyriproxyfen poses minimal risk to birds, fish, and mammals. So there's biologic plausibility. Then WHO is being more cautious and says the link between Zika infection in pregnancy and microcephaly has not been established. So they went to, this was like CNN or somebody, went to this professor, Andrew Bartholomew, who's a consultant toxicologist from the School of Pharmacy in Queensland, Australia. And he said studies in rats and rabbits have shown pyriproxyfen to have no reproductive or developmental effects at doses up to at least 100 milligrams per kilogram of body weight. This intake would be equivalent to an average human female consuming 6 grams of the compound per day. The acceptable daily intake of pyriproxyfen set by the WHO is 100 micrograms. This equates to approximately 6 milligrams per person per day. By contrast, the World Health Organization recommended the addition of pyriproxyfen to drinking water storage as a maximum of 10 micrograms per liter, which would deliver a dose of 20. A microgram is 1/1,000,000th of a gram. The intake of pyriproxyfen in Israel from treated drinking water is in the order of 300 times lower than the safe limit set by the WHO. So that sounds biologically plausible too, making it seem unlikely that this additive has any causal relationship. And what I've also noticed, and I'm sure many of you have noticed, is that none of the major news outlets, CNN, NBC, ABC, CBS, on their nightly news, they've not said anything about this. Everybody's nervous, waiting to see how it plays out. A lot of scholarly effort is trying to sort it out. So at this point, I don't think we know. Zika in Oregon, I suspect most of the questions and exposures will revolve around travelers and pregnancy-related questions. Life will be simpler if the congenital abnormalities are due to the larvicide and not Zika, but who knows how that's going to turn out. Questions or comments about Zika? I do want to get to a couple more cases. So I know probably lots of questions or comments. Okay. So, Dr. Kumar, that was for you.
Thank you.
You're welcome. Okay, the coughing cat. 56-year-old housewife lives on a ranch near Klamath Falls. Husband arrives for dinner on an early winter evening to find his wife on the couch gasping for air and immediately brings her to the emergency department. That morning at breakfast, the wife seemed fine, but she was concerned that one of the family cats had a hairball or something else, some foreign body obstructing the airway. The cat was coughing frequently and in apparent distress. The wife was seen to pry open the cat's mouth. No obstruction was found, but the procedure, prying open the mouth, stimulated the cat to cough spasmodically. In addition, and maybe unrelated, a plumber had just completed extensive repairs on the hot water system of the house. Other than the current problem, the wife was in good health. On physical examination, she was extremely ill, temperature of 40, tachycardia, tachypneic, blood pressure low, O2 sat very low. She was coughing during the examination, diffuse lung crackles bilaterally, but more on one side than the other, no lymphadenopathy. And she was producing moderate amounts of bloody purulent sputum. White counts 29,500, lots of polys and bands, platelets are low. The rest of the examination was fine, the rest of the laboratory data was fine. The chest x-ray was quite abnormal with a near whiteout, especially in the right lung. So, is this Legionella? This came up because of the work on the hot water system, which is the reservoir for Legionella. And you can jar it loose from the hot water system if you start playing around with the water pressure in the house. It'd be really unusual for Legionella to get you at death's door within 8 to 12 hours, which is what this history suggests. We already talked about the hantavirus hemorrhagic pneumonia. She lives in a rural area, certainly could have been exposed to the mouse droppings, et cetera, and this could have nothing to do with the cat. I suppose that's possible. Bartonella henselae causes cat scratch disease, can cause a variety of manifestations, but none of which is a bloody, acute, life-threatening hemorrhagic pneumonia. There's this variant of adenovirus. Adenovirus usually causes a mild interstitial or atypical pneumonia, but not a life-threatening pneumonia. And then there's tularemia and plague, which are the major concerns in this particular case. So the sputum contained gram-negative bacilli. So we wouldn't have seen the adenovirus, we wouldn't have seen the Legionella, that doesn't take up gram stain well, et cetera. Cat scratch organism, Bartonella, is hard to see on gram stain. So this wasn't a huge surprise when ultimately the blood and sputum cultures were positive for Yersinia pestis. So the cat was both indoor and outdoor. The cat picks up maybe from other rodents outside, either mice, rats, squirrels. The flea picks up the Pasteurella or Yersinia pestis from the rodent and then infects the cat. And this is the tularemia life cycle from the CDC. First of all, tularemia would be unusual in the winter because one of the major vectors are ticks or biting flies, and they're just not very much in evidence during the winter. Now, if you have an infected animal with tularemia and you are exposed to the infected flesh, and either by direct inoculation through the skin or inhalation, I suppose you could get tularemia, but that doesn't match the patient's history. So it fits better with plague, but most of us learned about plague as bubonic plague, starting with the infected, swollen, tender lymph node, then hematogenous plague, and then hematogenous pneumonia. And then getting plague pneumonia from another person requires that person to expose you by coughing directly into your face. So pneumonic plague can occur one of two ways, either hematogenous spread from the bubo to the lungs and then generating an aerosol, or in the case of our patient, we think the cat had pneumonic plague and was coughing directly into the airway of the patient. Patient was treated with ciprofloxacin based on the gram stain, and then once we knew it was Yersinia pestis, the patient was switched to definitive therapy with streptomycin. Statistically, the mortality rate is 80 to 90%. The patient required prone mechanical ventilation and transient extracorporeal mechanical oxygenation, but actually ultimately recovered. The cat did not recover. So a pneumonia that can kill you in 24 hours, we talked about plague and tularemia spread by horseflies, ticks, mosquitoes, etc., anthrax, and now I brought up plague. So these have all been agents considered as potential bioterrorism agents because of the lethality when the exposure is directly into the airway. Any questions? We're doing pretty good because I really wanted to get to this last one. Okay, I'm dying. 72-year-old female suffered severe right temporal headaches with new onset jaw claudication, no visual symptoms. Sed rate was only 20 C-reactive protein, up just a hair. Right temporal artery was biopsied because this probably is giant cell arteritis, temporal arteritis, but it was negative. Nonetheless, the patient was started on prednisone, 30 milligrams twice a day. Diagnosis, temporal arteritis. Over the next 2 months, the patient got worse, not better. Progressive bilateral arm pain was a major complaint, intractable fatigue, anorexia, and dramatic weight loss. exam was most remarkable for no detectable radial pulse in either arm. So she was sent for angiography because of that finding. And the results, I'll show you the pictures in a minute, showed this stenosis of both right and left subclavian arteries, occlusion of the left axillary artery. The prednisone was continued. 7 months later, patient was not very compliant. She had gangrene of the left hand. Carotid to brachial artery bypass surgery was done as an emergency to forestall the impending gangrene of the hand, and the prednisone at that point was stopped. 16 months after her initial evaluation, her weight was down to 30.8 kilograms. She had flexion contractions of her fingers, which were felt to be the result of ischemic injury, and had absent arterial pulses, both radial, left popliteal, both dorsalis pedis pulses. SED rate still is not very dramatic. C-reactive proteins only 0.3. So repeat angiography showed focal narrowing and/or occlusion of multiple large arteries. So I think the arrows are self-evident. I hope you can see them. It's the subclavian arteries, major branches off of the aortic arch, and here's multiple skip lesions in the subclavians that are demonstrated there. And then off the abdominal aorta, there are these peculiar bulges and then stenotic lesions as well. What's going on? We need help. Patient's going to die.
Takayasu's arteritis.
Yeah, Takayasu. So a vasculitis. So we started out with temporal arteritis, and now we've got the larger blood vessels involved, raising the possibility of Takayasu's angiitis or giant cell arteritis of large vessels. Polyarteritis nodosa would usually be the smaller vessels, and then the question of other. So there was re-examination of the temporal artery biopsy from 14 months earlier. 17 sections were involved, and they documented now in hindsight the presence of giant cell arteritis with skip lesions. What else did they find? They found the antigens and DNA of varicella-zoster virus. And this demonstrates with a rabbit anti-varicella-zoster antibody, all this pink stuff is the zoster virus, if you will. And other investigations looked for the DNA of the virus, and that was also strongly positive. It was mostly in the adventitia and media of the arteries as opposed to the intima of the arteries. The patient was not given any more prednisone, but was given intravenous acyclovir, 15 milligrams per kilogram 3 times a day for 2 weeks, and then switched to valacyclovir, the oral equivalent, 1 gram 3 times a day. Within 1 week, her appetite returned. She had gradual return of temporal, radial, and popliteal artery pulses. After 4 months, her weight, which had natered down around 30 kilograms, was up to 39.5 kilograms. So the JAMA called this one of those N of 1 cases. It was in JAMA Neurology last year. Dramatic case that suggests that giant cell arteritis and Takayasu's disease are part of the spectrum of the same disease process. And varicella-zoster virus might be the etiologic agent for both. Varicella-zoster virus antigen was found in 74% of the arteries of giant cell arteritis patients versus 8% of normal temporal arteries. I'll show you that table in just a second. The patient presented is still under investigation, actually, by Dr. Holland at the National Institutes of Health because of the severity of the vasculitis involving so many vessels. They suspect that there's an underlying immune deficiency. To explain the severity and widespread nature of the infection and the fact that the SED rate was so low that suggests a poor host response. So this is the analysis of varicella-zoster virus in temporal artery biopsies, positive and negative for giant cell arteritis. Temporal arteries that were giant cell arteritis positive or negative, the differences are quite clear. Confirmation, this is Dr. Gilden's group from Denver, and the results have now been confirmed by 2 other groups of investigators. The conundrum is these patients don't have a skin rash. They don't have shingles. They don't have vesicles that we can test. So the staining of the temporal arteries with varicella antibody is still a research test. We need a better diagnostic tool. This is all stuff that only works in an investigative laboratory. Then one last thing to titillate you with was just we reported increasingly the association of varicella-zoster with aneurysms, especially in young people. This is the rapid development of, this is the most extreme example, the rapid development of 9 cerebral aneurysms in varicella-zoster vasculopathy. Again, Dr. Gilden and his group. This was a patient with systemic lupus on immunosuppressive therapy, had zoster or shingles and multiple dermatomes, severe headache, normal magnetic resonance angiography and 4-vessel digital subtraction angiography, developed 9 anterior circulation aneurysms, some of which disappeared months later. But you can count them. I hope you can see all these. This is the standard angiogram, and there's 1 aneurysm, 2, 3, and here's 5, 6, 7, 8, 9. And then they do this fancy subtraction technique, which I don't understand, which shows the aneurysms in a rather dramatic profile, if you will. So the full spectrum of varicella-zoster virus disease is exploded, and numerous investigators now are trying to figure out how we can nail this down, how we can have better diagnostic tools, how many folks with bleeding intracerebral bleeding due to aneurysms, intracranial hemorrhage, have an underlying zoster as varicella-zoster as an etiology. How many patients with strokes who don't have a skin rash have varicella-zoster? Should we be treating temporal arteritis with acyclovir or the equivalent as opposed to prednisone or the 2 together? That study is in progress, more to come. Dr. Gilden and his colleagues, I think, however this turns out, deserve recognition for their leadership in trying to bring this to light so that we can get hard data. I presented a similar case last year because I think it's such an important area where the impact on clinical care is obvious and needs to be reconsidered. And with that, I think I'll stop. Can I have the lights up, see if there's any comments, especially from Dr. Wernick, who sees a few patients with temporal arteritis. Richie, any comments?
Dave, had these patients gotten zoster vaccine? Is it possible as a live attenuated virus that's a risk factor for getting this in certain hosts?
Yeah, so the zoster vaccine is a live attenuated vaccine, and I should mention that the inactivated zoster vaccine, which is even more immunogenic, is in the final stages of FDA evaluation, and will probably take care of that. So we give live virus to the kids, the varicella zoster vaccine. And there have been anecdotal reports of aneurysms and arteritis in the kids. They have no pre-existing immunity. There have been no such reports with the live attenuated zoster vaccine, and they think it's because there's some pre-existing immunity. So the host response is not the same in the adults because they've already been exposed as compared to the kids. That's sort of a teleologic explanation, but it has some biologic plausibility.
Questions?
Oh, come on, you guys.
So do you think are there any practical implications of this right now?
Practical implications, if you have somebody with unexplained intracranial hemorrhage and you see the aneurysm and we have the spinal fluid, we can do antibody tests on the spinal fluid. You don't need a research lab. You can do an antibody test, antibody titer on the spinal fluid, and compare it to the antibody titer in the peripheral blood, and if the ratio is reversed, you can start antiviral therapy. That would be a reasonable thing to do. But there's no non-invasive way of making the diagnosis. Yeah?
If zoster is so prominent in the etiology of temporal arteritis, why do you think prednisone has been so successful over the years in treating this?
Well, the definition of success, I'd love to have Dr. Wernick comment, because how many of your patients continue to have periodic flares, relapse? You know, I've heard Richie and Steve Campbell talk about this for years, and you know, you start them on the high dose and then you taper them down, and how many patients seem to simmer along? You know, when do you stop? I mean, yeah, they respond, but you know, we used to think ulcers were just due to acid, but now we know that Helicobacter is there. So it does change your way of thinking about it. I don't know what Richie thinks.
I would say medical therapy is very successful for giant cell arteritis, and I think this is a clearly contrast to Dave's mantra over the years. This clearly shows that some infectious diseases are probably rheumatologic instead.
My next approach to Dr. Campbell and Dr. Wernick is I think we ought to invite Dr. Gilden to come and present his data directly.
This is feeling a little bit like the early days of H. pylori, maybe?
It does. It does. Yes, Dr. Wernick.
Dave, should the pathologist be looking for zoster when we send the patients off for temporal artery biopsies?
Yeah, thank you. You're making me feel guilty. Dr. Bonafide is saying, well, why don't we start looking with the zoster antibody? They have all kinds of antibodies that they use for other purposes. They know how to do it. We just have to get them the reagents. And it was my intent to talk to our pathology colleagues before this presentation, and I just never got around to it. But I promise you I will. Right. We should do it. Yeah.
Well, I'm old enough to remember when we used to treat shingles with prednisone
Yes.
in the 70s.
Yeah. So now the question is, should we be treating shingles with acyclovir or valacyclovir instead of prednisone? And that's the study that's underway.
Is there any association with polymyalgia rheumatica, or can you?
I haven't seen that sorted out. Have you? No, the focus has been on temporal arteritis. Okay, well, thank you all very much.
Thank you for a great grand round. Right, I get better without querying experts. And more time for information.
Yeah,
I think it's
yeah,
better.
that's what I
Maybe for the
decided.
idea, so it's different.
Well, yeah, because we want to show off our guests and all that kind of stuff.
Different.